Hello, I am going to speak to you today about, about a treatment that I conduct as a licensed clinical social worker. This is called Dialectical Behavior Therapy, and I believe it can be very helpful for people with EDS and HSD. I'm speaking to you as a patient, as a social worker, as a mental health therapist, and as a DBT enthusiast. So what is DBT? DBT is a structured program of psychotherapy with a strong educational component that's designed to provide skills. It's a skills-based treatment. It is conducted over a period of 6 months to a year. And it was originally developed for people with a condition called borderline personality disorder, people who are struggling with chronic suicidality. And I mention that because it will be relevant later on. DBT is founded on this concept that is a little bit hard to wrap our head around, so I'm going to try my best to explain it. It's the concept of dialectics. So dialectics is like a teeter-totter, okay? There are two seats on a teeter-totter that reflect opposite sides or truths that can exist at the same time. So for example, I already told you that I am a patient and I am a social worker. And sometimes those seem like they're in conflict, especially when being a patient feels like a full-time job. However, they can coexist. And this treatment is aimed at helping people balance those two realities. So this is just a visual to help people understand the concept a little more thoroughly. We see here a little green square looking at this shape from a certain angle and saying, it's a square, I see a square. And the circle's arguing, no, it's a circle. It's obviously a blue circle. Look at it. And the issue with this is you get stuck in one way of seeing. They're rooted in the ground, looking from one perspective. And if we zoom out, the solution is to look at the bigger picture. And this is what we refer to as dialectical thinking. Because in reality, if that little green circle, the little blue circle is standing in one corner of the room looking at the object, and the green square is standing at the other corner of the room looking at the object, both of them are right? They see a circle and they see a square. But if we zoom out, we can see both. And that's what we can do when we hold the fact that we are both patients and we are moms, we are teachers, we are nurses, we are all these other things. These are just some of the dialectics that we struggle with while living with EDS. We've talked about this a lot today. We are often told by practitioners that our symptoms are all in our head. But we have all stood up here to talk to you today about how your mental health also has an impact. It's not one or the other. It's both that mental health has an impact and there's a vast physical component to our suffering. The same is true about having good days and bad days. We can have bad days that have really good moments. And it's important to be able to hold that. And we can have good days that have those darn bad moments. And we can't let the reality of those two cloud the other. We talked about this a little bit yesterday. There was a wonderful talk about mistrust in the clinician-patient relationship. Okay, so we have to find this balance between trusting ourselves. We are the experts of our body, and we go to experts for their wisdom and knowledge in their area of expertise. And so we have to balance that, and dialectical thinking can help us do that. We might often feel alone in our suffering when we're at home, in bed, in a lot of pain, and then we come to a space like this, and we realize people do understand us. We're not alone. There's a whole community behind us. And then finally, we've all been on the roller coaster of hope and hopelessness. And so finding realistic expectations in between that help sustain us is really important. So there becomes this question of why there are so many of these dialectical dilemmas when you're living with EDS, and I think this is something worth mentioning. They exist for everyone, but the extremity of them is profound in EDS patients, and that is in part because of the way that the medical system is structured and this idea that there is a disease hierarchy, and that hierarchy dictates how much research funding goes into specific conditions, how much hospital dollars, how much hospital space, how much attention in the media, how much awareness socially exists. And at the top of the hierarchy the conditions that receive the best care and the most funding are those with unambiguously located conditions. So things like heart attacks, brain tumors, and unfortunately at the bottom where we see the least attention, the least care, the least validation are conditions like our own. And that is why they are referred to as low prestige diseases. And low prestige diseases are inevitably fraught with invalidation from medical professionals, a lack of awareness from the people around us, insufficient funding, and poor treatment options, which makes these extremes or these dialectical dilemmas all the more severe. So I go back to this concept of being chronically invalidated. And the treatment developer who's here up on the screen, she's one of my heroes, Marsha Linehan, she developed dialectical behavior therapy for folks who were chronically invalidated by the experience of living with borderline personality disorder. Not only did people with BPD often grow up in chronically invalidating environments, which in fact led to their condition, but the condition was then subsequently stigmatized very awfully in the mental health profession. Patients were considered untreatable. No one wanted to work with them. And I think as EDS patients, we can relate to that. And so that is one of the reasons why a treatment that was specifically developed for folks who are chronically invalidated would make sense for folks like us. Our invalidation might be different than those with BPD, but we can still benefit from similar interventions. Additional rationale exists for why DBT would work, and evidence, actually. So there's a wonderful researcher, she's a dear woman, Deborah Barrett at the University of North Carolina, and she has shown how dialectical behavior therapy can be adapted for pain management specifically. And she did this based on the idea that because DBT was developed for emotion dysregulation and chronic pain is conceptualized as sensory dysregulation, then the skills would be applicable to both. And she has shown it to be effective. And finally, when Marsha was developing this treatment, she was working with folks who had been suicidal for years and years and years, and she quickly realized while she could go to extreme measures to keep them alive, that was not enough. She did not just want a suicide prevention program. She wanted to build a life worth living program. And so she hearkens on this idea that he who has a why to live can bear almost any how. And our how as EDS patients is heavy. It's heavy, it's arduous, it's burdensome. And when we can really hone in and focus on finding our why, it can make a big difference. And DBT is a way to facilitate that exploration and the solidification of your motivation. So how does DBT work? It is taught in 4 modules, and I'm gonna review them, and all of them are aimed at minimizing suffering, which who doesn't wanna do that? The first module is what we call emotion regulation. Living with complex chronic illness that is chronically invalidated inevitably forces us to face a lot of negative emotion. And having skills that allow us to turn down the volume on those negative emotions are life-changing, and that's what emotion regulation skills do. Living with a chronic pain condition, inevitably, there are times where we will experience waxing and waning, right? And when we are in the midst of a flare, our goal sometimes can't be to totally get rid of it. Our goal has to be not to make it worse while it's that bad. And distress tolerance is an effective way to manage that. And then finally, there is so much need, as we've talked about earlier today, about advocacy, right? Our last speaker just spoke so well on advocacy, both for our community, but for ourselves. And our ability to clearly and effectively communicate our needs to our caregivers, our friends, our healthcare providers comes from this idea of interpersonal effectiveness. And then finally, the bedrock, the foundation of these skills is mindfulness. So we repeat the mindfulness modules throughout the entire year, each time we introduce new skills, because of how integral they are. We use the analogy that the previous skills that I mentioned are like the way you turn the plane, the way you go up and down in the plane, you increase the speed or reduce the speed of the plane. It's how you fly the plane, right? But without mindfulness, it's like trying to fly the plane with your eyes closed. So mindfulness is necessary in order to incorporate any of the other skills. I also want to mention what we refer to as DBT's non-identical twin. Okay, so we've talked about the spectrum of neurotypicality and diversity today, and there also exists a spectrum along the lines of self-control. So people who benefit from DBT are often struggling with emotions running the show and getting kind of hijacked by emotion in a way that makes them somewhat impulsive sometimes, and then they look back and they kind of regret what they did. There's also another variety of DBT that was developed for people who are over-controlled. These are people who become paralyzed by anxiety and fear. They are definitely the people who think before they act, and sometimes they overthink to the point that they never act, and it becomes problematic in their life, and they can become very isolated. And so RO-DBT was developed for just this different type of person. And there are a couple signs that you would benefit from RO-DBT more than DBT. If you find yourself particularly lonely, you find you have compulsive needs for fixing or structuring things, if you feel particularly perfectionistic or rule-governed, then RO might be a good place for you. Another sign is if you struggle to pick. So these aren't the only two options. There are so many mental health treatments out there, and I want to mention a couple more evidence-based treatments that could be a better place to start if you feel like these descriptions are more applicable to your situation. So I mentioned this one already, but if pain is your primary symptom, if that's what you're struggling with the most, dialectical pain management is a wonderful treatment, and it's a shorter-term treatment as well. All of these are generally shorter-term treatments. Also, cognitive behavioral therapy is a great place to go if you feel like things are out of control and you can't stop worrying, if you're haunted by rumination. If you're feeling really lost, especially with that idea of not knowing your why, a treatment called acceptance and commitment therapy is a wonderful option. If you're struggling with avoidance of a specific thing or panic attacks, exposure and response prevention is a good treatment to consider. If you feel like you can't relax, if you can never relax, you just feel like a tightly wound ball of string all the time, mindfulness-based stress reduction is a good option. If you've experienced trauma and you're continuing to feel the effects of that trauma, we've spoken about medical trauma. That's a very good example for how this treatment could be used. Eye movement desensitization therapy is a treatment that you could look into. If you have completed DBT and your trauma symptoms are persisting, DBT prolonged exposure would be the next place to go. And then finally, if you're just feeling overwhelmed and you're ready for change, mindfulness-based cognitive therapy is a great option. These are all within the same families, as you can probably imagine. It's behavioral treatments, and some of them are considered third wave treatments that incorporate mindfulness, that really integral component. So then the question is, where do I start? How do I find these people? And it's really, really important to look for certified and trained clinicians, especially if you're seeking an evidence-based practice. So there are certification boards and things like that that provide databases, and I shared a couple here. You can also, of course, financial consideration is important, and you can also sort by insurance using this Psychology Today. That's the most popular database that we have out there right now. And I would be remiss if I did not mention that the most important predictor, research has shown this time and time again, the most important predictor of success in mental health treatment is the therapeutic alliance, which is your relationship with the therapist. And so if you are not comfortable with the person you're working with, continue to shop around, okay? It's really important to find the right fit. It doesn't matter what treatment you do if you don't have a good fit with the therapist. And I finally wanted to end with a patient testimonial from an EDS patient who's currently receiving DBT at our clinic. They said, learning to utilize these skills is life-changing for me. DBT makes an incredible difference in how I think, feel about, and overall manage my hypermobility and chronic pain. I am able to process big emotions like grief and move past my fear and anger to focus on treating my symptoms. It is much easier to stay on top of my meds and appointments. Being mindful of my movement and diet helps reduce injury and GI distress. I am learning to radically accept my diagnosis, which helps me have lower pain levels due to less mental suffering. I am amazed at the improved quality of life I experience when using these skills. Thank you for listening, and as we say in DBT, I wish you skillful means and a life worth living.